Good afternoon to one and all present here. I, Dr. Gupta, welcome you all to Mahatma Physiotherapy College for our 14th Physiotherapy Combined Round, PTCR, which would be on the topic 21-year teaching with right hemiparesis due to left FTP Glio Sarcoma. This case presented to our university and went to the radio oncology department, from where it was referred to our department of radiotherapy as the patient was having hemiparesis. I would like to welcome Dr. Shahid Siddiqui sir, Professor in HOD, Department of Radiation Oncology, MGMCH. Also, I would like to welcome Dr. Shiva Dehal ma'am, Associate Professor, Department of Radiation Oncology, MGMCH. Welcome sir and ma'am to our college. Also, I would like to welcome all the three speakers, Dr. Diksha Shrimali, Junior Resident, Department of Radiation Oncology, Dr. Shilpi Tank, PG Resident, MGPC, Dr. Ashis Sharma, PG Resident, MGPC. Also, under the guidance of which Dr. Rakesh Khandelwal sir, I would like to welcome you as well, Associate Professor, MGPC. We'll start with our today's PTCR round. With the first, I would like to invite our speaker, Dr. Diksha Shrimali, and she would be telling us about the radiation oncology of this patient and how this patient was presented to them. I would like to welcome you.
Good morning, respected dignitaries, teachers, and vital fellows. Myself, Dr. Diksha Shrimali, testing here for the 14th PTCR. And to begin with our case, patient of XYZ, 22-year-old female from Kolkata, complains of weakness at right arm and legs, facial weakness, and sudden onset of headache, vomiting, or normal body movement, facial negation to the left side, since August 2026. There is no history of comorbidities like hypertension, diabetes, and any other things. All the investigations are damage came out to be normal, but MRI was suggestive of a large, heterogeneously hyperintense diffuse lesion measuring around 9.5 into 5.4 and 5.2 centimeter in the left frontal right temporal lobe with a hand mark effect and 8.6 mm of midline shift. All these investigations were done outside and surgery was also performed outside. So she went left frontal temporal parietal decompressive radiography outside. After that, histopath report was revealing of undifferentiated spindle cell neoplasm. IHC panel was done and it was suggestive of Sarcoma. Post-op CD was done, which was suggestive of left-sided frontal parietal temporal radiography stages with sublingual hematoma. Likely possibility of post-op changes. Then the patient was referred to Radiation Oncology Department for the further management at our institute, MGH. We then further proceeded with the examinations. So for the radiological examination, higher renal functions were seen, that she was less oriented, she was confused, but she was following the commands like time, pace, and focus. She had a slight weakness of on the right side. While doing the motor examination, left-sided upper and lower limb power was around 4/5. She had a decreased sensation of proprioception and tensile sensation on right side. Her balance and coordination was impaired. She was unable to ambulate independently. Following the initial presentation and diagnosis, we are following the multidisciplinary human board team at our institute. Now the patient was planned for adjuvant radiotherapy, which is to a dose of 60 gray by 30 fraction, along with the concurrent chemotherapy at the rate of 75 milligrams per meter square. That's the chemotherapy. And this whole process takes around 1.5 months. Now, I would like to tell about temozolomide. Temozolomide is a chemotherapy which is given 45 minutes before the radiation treatment and should be given empty stomach. And it should also be given on Saturday and Sunday when the radiation treatments are not given. It should be given for the entire treatment. Then, with the proceeding, first we need a mold. Mold is made so that the patient position can be fixed, and so that there will be no error while doing the radiation treatment. A customized head mold was created using the thermoplastic material. And after creating the mold, a CT simulation was done. We had a wide CT board and laser, which is simulating same as the linear accelerator machine that is in our department to give the radiation. After doing this, the whole CT simulation was done. The CT was imported to our system variant, from where we delineated tumor by making following structures like GTV, that is gross tumor volume, CTV, that is clinical target volume, and PTV, that is planning target volume. So basically, GTV is a gross tumor volume. The entire tumor is covered in GTV. CTV is the clinical target volume. If there is any microscopic extension present, then it can be covered by CTV by giving the margin of around 0.5 to 2. And to cover the entire GTV and CTV, we make a PTV, that is planning target volume. So that if there is any setup error, it will be covered by that. Setup error can be possible while during the treatment if the patient position is not fit, the patient is moving, or his load is not fit, then PTV allows us for the treatment of the entire coverage. After completing the radiotherapy, temozolomide was stopped for around 28 days. Then the patient will review for adjuvant temozolomide at the rate of 150 milligrams per meter square to 200 milligrams per meter square for 12 cycles after every 28 days. When the patient will review to our OPD, first we'll take the BMI of the patient. Then we will first describe the dose by 150 milligrams per meter square. Then the subsequent settings, the dose will be 200 milligrams per meter square. This is how the simulation is done. We use the thermoplastic mold to make the mold of a patient. This is for the brain, head and neck cancer and brain tumor. This is the mold. Patient died supine in spine position on the treatment table. And it has thermoplastic mold is being molded to 65 to 70 degree temperature. After heating that, the mold is formed. Now, using the various treatment planning systems like computerized treatment planning, dose calculation, or planning optimization, which is done by a medical physicist to form the entire plan. Plan optimization means planning optimization aims to maximize tumor dose, means the entire gross tumor volume should get the 100% coverage so that no further radiation should be required. CTV gets around 95% coverage. This is how the contours are laid, the red one, the red arrow. This is our GTV, that is the cross tumor volume, the lesion which we saw in the MRI. And if the patient is post-op, so we give radiation to the post-op bed. This is the GTV. Then giving the 0.5 to 2 centimeter margin, we draw a CTV, that is clinical target volume. And to reduce the setup error, we give a PTV, that is the planning target volume. While doing the planning, the medical physicist forms DBS, that's a dose volume histogram, that shows that at which organ, how much volume and how much radiation should be given. This deeper one is saying that the dose is around 95%. This gap should be more compared. That means that the lamin is formed perfectly. Then this is the color wash. Color wash shows that the 95% coverage is present, which shows that the planning is done with accuracy. Now, adjuvant temozolomide. After completing radiotherapy, temozolomide was stopped around 28 days. The patient will review for our department for adjuvant temozolomide at 150 milligrams per meter square to 200, depending on the setting, for 12 cycles after every 28 days. Now, as part of our holistic treatment, we refer our patients to physiotherapy department. Now, I would like to give an insight about our department and radiation therapy. So, radiation therapy is mainly due to production of X-rays, which are reduced in X-ray tube that uses the high energy penetrating waves or particles such as X-rays, gamma rays, proton rays to destroy the cancer cells. There are two machines at our institute. The machine is linear accelerator. There are two types, true wave and wave. So basically, this is the gantry. Gantry rotates around, this is the treatment couch and this is the gantry. So the gantry rotates around the treatment couch, giving the radiation to the patient equally. This is the MLC. MLC is multi-leaf collimator, which improves the irregular tumor to give the shape, which improves the beam or modulates the beam to give the irregular tumors. These are the radiation arms. This is the cone beam CT scan, which shoots the CT of a patient. And the difference between a true beam and unique is that unique uses a single energy, that is 6 megavoltage, and it's used to treat the palliative treatment as well as lower end technologies. While true beam has a multiple beam, that is 6, 10, and 15 megavoltage. It used to treat the deep-seated tumors, even the superficial tumors, as well as electron post therapies are also given using the true beam machines. Now the technological evolution in radiation delivery system. First, there was two-dimension. Two-dimension had no computerized planning, so there was no conformity to tumor. So because of that, the tumor coverage was very less, which causes the higher dose toxicity to the patients. Then they came up with 3D CRTs, that is a conformal technology, three-dimensional conformal radiotherapy. 3D CRT uses computer planning. So because of computer planning, tumor coverage was very much increased, due to which toxicities were also decreased. Another thing is two-dimension was done in two fields, either square or rectangular. So that coverage was not possible. Three-dimension had the proper coverage. Then we come up with the IMRT, that is in three-dimension also uses 3 to 7 beam maximum. While other IMRT, intensity modulated radiotherapy, uses around 5 to 7 beams or 9 beams, and each beam is divided into beamlets, so that the beam get modulated and intensified, which shows which easily cover the tumor size and modulation is possible as per the beam IMRT. It can also be used for SID, that is simultaneous integrated post therapy. Then we come up with the IGRT. IGRT is image-guided radiotherapy. Image is being taken, CT scans are taken before the radiation therapy is taken, so there is no any setup error there. The first simulation was done where the CT scan was taken. Then another CT scan was taken just before the radiation therapy. So that there is no setup error. Now, if the patient moves, if the patient's mold is loosened or something, we again form the mold and we again do the simulation so that there is no error, no chance of error. Now, rapid eye to BMAT. All these other processes takes around 45 minutes or 30 to 45 minutes, and rapid eye to BMAT planning takes around 5 minutes. So this is very accurate and precise planning. This is the rapid arc. It's formed in the form of arcs. Planning is formed in the form of arcs, which is easy and rapid. This is the MLC. Earlier in 2D there was jaws. Jaws is moving upside down. So that only two-dimension fields were formed. Then we came up with MLC. MLC had a 3 dimension, each side by side and upward. Both leaflets were present, so that we can easily delineate the irregular tumors also. Now we have another stereotactic body radiation therapy. So stereotactic body radiation therapy delivers very precise, high-dose radiation to a very small, well-defined areas. It uses specialized immobilization and image-guided techniques to achieve the sub-millimeter accuracy. So in all other therapies or treatments, there were around 30 to 35 sessions. Now in this, there is only 1 to 5 sessions, but each session has increased radiation compared to the 30 to 35 sessions. That's also known as hypofractionation. So allows for hypofractionation, delivering the full course of treatment in around just 1 to 5 sessions. Commonly used for the early stage lung cancer, liver, spine, and other metastatic tumors. We have recently come up with the Cyberline, that is a robotic radiation system. So let me tell you about this. This is the lilac machine, which was earlier also there, and this is the robot. Now the entire machine rotates around the treatment couch to give the treatment, while other machines like TrueBeam Light or unique machines were stationary, so they were not able to rotate around the treatment couch. Along with that, it has automated beam tracking. So while rotating, it can track the beam constantly, while previously it was not possible due to it was stationary. It's a non-invasive frameless SRS or SBRT, stereotactic radiosurgery or stereotactic radiotherapy. It minimizes exposure to healthy tissues. This is the X-ray source. This is the linear accelerator. This is the robotic arm. Here we have image detector and this is the treatment couch. So the entire robot rotated around the treatment couch, giving the radiation. These are the codes that are fit in the linear accelerator according to the patient's lesion size, and then accordingly treatment is given. Thank you. Now I would like to call upon my physiotherapy colleague for further management. Physiotherapy rehabilitation. Day 1, firstly we started with the assessment of patient. Patient information, as we already discussed about the history of patient, we let's further move on to the physical examination. So as per our report, vital signs of patients are stable. On examination of the patient, BP is 120/75, pulse rate 75 per minute, and SpO2 100% at room temperature. We further move on to the neurological examination. So higher mental function, patient is less oriented about time, person, place, and confused but following commands. Facial weakness slightly on right side due to the hemiparesis on right side. Motor examination, left side motor power is normal, right side with the same next on the table. MMT, left side power is 4 out of 5. Right side we discuss in next table. Here the MMT charting of right upper limb and right lower limb. Shoulder flexion range for the initial days is 1 plus, and passive range of motion is overhead movement are painful. Due to the improper handling of the shoulder or hemiparesis shoulder, patient is unable to do or perform overhead movement. And shoulder abduction power is 1 plus, overhead movement again here is painful. Like this, elbow flexion range is 1 plus, and the passive range of motion is normal. Like this, right lower limb hip flexion rate is 2 plus, passive range of motion while 110 and 110. Sorry. Neurological examination further continue. Reflexive damage on the right side, sensation decreased, proprioception and tactile sensation on the right side. Balance and coordination impaired. Patient has very poor balance in sitting and standing also. Gait unable to ambulate independently, and we started trained for gait or we started for walking. Patient has a hemiparesis gait. ADL is dependent in all the ADL activities. We can see here in the picture, patient is wheelchair bound. We further move on to the physiotherapy management. So here the physiotherapy goal, relief of pain, mostly in right shoulder, prevention of contracture, then further restore and maintenance range of motion, improving and restore muscle strength, then further move on to the improve posture and balance of the patient, improve gait pattern and improve the functional independence of the patient. Treatment plan frequency 5 times per week. Duration 45 minutes to 1 hour in a session. Progression gradually increasing exercises in intensity and duration according to the patient condition. Physiotherapy intervention. Firstly, we started with the therapeutic exercises, range of motion exercises for upper limb, trunk, and lower limb. Firstly, we started with the passive exercises, then progressed to the active assisted exercises, and then further active exercises. Standing exercises for right upper and lower limb, PNF exercises. These are the neurofacilitatory techniques which facilitate neuro impulses to recreate muscle through proprioceptive stimulation. Then closed kinematic chain exercises and stabilization exercises, weight bearing on right upper limb in sitting, reflex inhibition techniques for upper extremities, weight shifting exercise for lower limb extremity. We can see here in picture the passive range of motion exercises for upper limb and the passive range of motion exercises for lower limb. Here's the video of passive range of motion exercises of lower limb. When we progress on to the balance and coordination exercises like frontal exercises, marching exercises, vestibular wall exercises, and mobilization technique like bendal rhythmic passive movements, passive and active assisted range of motion exercises, pelvis rotational exercises. Here are the picture of active assisted movement for upper extremity of the patient and the active movement for lower limb. Then further move on to the functional training of the patient, functional re-education. Firstly start with the supine position. Activities involving like looking, breathing, supine to sideline, slow head touching to the opposite shoulder and hand touching to the opposite head. In setting, we included activities like sitting training, sit to stand, stand to sit, stand to silence, hand to ear, hand to nose, and hand to mouth for improving their ATL activities like feeding. In standing in parallel bar, activities involving standing in parallel bar, hip hiking, and weight shifting. Then activities of daily living training, step up and step down exercises, and transfer training. This is the video of patient actively shifting their actively transferring in the bed, sideward transfer. You have a picture shifting weight backwardly in the bed. So these are the transfer functional activity of patient. We further move on to the gait training. So gait training, we started with firstly the gait training in parallel bar. In activities involving gait shifting, stepping forward, backward, sideward walking, turning, backward walking, and progress to the independent walking. We can see in the pictures the independent standing of the patient. There is the independent walking of patient. So after the rehabilitation completion, patient is able to walk independently without any assistive or supportive devices. Outcome results. So we organized a reassessment after the 1 month of rehabilitation on 23rd October 2024. Here the charting of muscle strength improvement. We can see here the shoulder flexion muscle power at the initial days is 1 plus and at the time of discharge is 3 plus. Like this, in the lower limb, hip flexion power is 2 plus at the initial days and at the discharge or post-week of phase, the patient improved 1 grade, is a plus 3. So like this, we can see here all the muscle ranges differentiation. Then Barthel index for ADL activities. Initial days where we see all the ADL activities, patient is dependent in all the ADL activities, and after the rehabilitation, the patient needs less assistance or mostly independent in all the ADL activities like feeding, bathing. Then patient education and home program. Firstly, we advise patient to continue the physiotherapy treatment or exercises, ADL activities, and increase involvement in the functional activities. Patient and family member counseling, patient and family education on exercise and safety. Lastly, we advise patient to must continue the physiotherapy treatment to more improvement and improve the quality of life.
This patient is still not totally independent. So do you think that a more prolonged treatment would help the patient? Number one. Number two, once she goes home, if she doesn't take any physiotherapy assistance, is there a possibility that she can go down again?
Yes, sir.
So,
Possibility. Actually, these are the muscle power. So, if आप कोई भी चीज यूज नहीं लेंगे वो वापस नहीं.
so that is a very important part of, because see, most patients, one, they may not understand. Second, even if they understand, they may not follow.
Yes.
And therefore, it is very important that whatever gain has been made in 1 month, that is not lost when the patient goes back from the home. That is important. Second, that you people must remember the day when I addressed you when you joined, I said that no post, no profession, no job is more or less important. कैंसर के पेशेंट में सर्जन ने ऑपरेशन करके कैंसर जितना निकल सकता है सेफली वो निकाल दिया. उसके बाद रेडियोथेरेपी की टीम ने जो बचा हुआ कैंसर है या कुछ कैंसर्स प्राइमरीली रेडियोथेरेपी से ट्रीट होते हैं बिना ऑपरेशन के, उसको कंट्रोल किया. कुछ पेशेंट्स को कीमोथेरेपी भी मिलती है. लेकिन इन सब ट्रीटमेंट से पेशेंट की जो फिजिकल परफॉर्मेंस है वो कम हो सकती है, जैसा इस केस में हुई है. शुरू में नहीं आया था, बट आई कैन अंडरस्टैंड कि ये ऑपरेशन के बाद हुआ है या रेडियोथेरेपी के बाद हुआ. अब उस समय पेशेंट कैंसर को भूल चुका है, बिकॉज हमने उसको बोला कैंसर निकल गया, कैंसर हमने बीच से इलाज से ठीक कर दिया. अब उसके मन में कैंसर या लाइफ की चिंता नहीं है. अब उसकी जो मेन प्रॉब्लम है वो ये है कि मैं अपना काम कैसे करूं. पहले मैं चलती फिरती थी, अपना काम अपने आप करती थी, अब नहीं कर पा रही हूँ, मुझे असिस्टेंस की जरूरत है. सो दिस इज वेयर यू पीपल प्ले अ वेरी वेरी इंपॉर्टेंट रोल. ऑपरेशन में भी होता है कि कितना बड़ा ऑपरेशन हुआ उसकी चिंता नहीं होती, वो टाके गिनते हैं कितने टाके लगे. हमें सबको पता है कि टाके इंपॉर्टेंट नहीं है, पेशेंट के लिए तो वही इंपॉर्टेंट है. तो इसी तरह से क्वालिटी ऑफ लाइफ पेशेंट की बहुत इंपॉर्टेंट हो जाती है उस स्टेज पे जब उसका कैंसर से डर लगता है. इट इज वेरी इंपॉर्टेंट कि आप लोगों का रोल उस समय बहुत जरूरी होता है, खासतौर से जिन पेशेंट्स को न्यूरो सर्जिकल ऑपरेशन हुए या स्पाइन के ऑपरेशन हुए या ऑर्थो के ऑपरेशन हुए. एंड योर ट्रीटमेंट इनफैक्ट अगर आप पेशेंट से पूछें तो शायद वो आपके ट्रीटमेंट को ज्यादा वैल्यू देगा बनिस्बत की जो ऑपरेशन या फिजियोथेरेपी कीमोथेरेपी या रेडियोथेरेपी को, तो वो तो उसके हाथ में नहीं. That is why again and again I say that don't think that you are playing a less important role than anybody else in the holistic care of the patient.
Yeah, about something some things about the home side and have a lot of follow up. What we can do, we can give one of all the exercises in the paper when they are open, we can give open exercise to the patient. We can also provide video the exercises. What can be exercise the same before following and what can be exercises. So some exercises patient can do by self. Also with the help of three or pretend. So this kind of thing we can do. Also we can start daily physiotherapy to the patient who are living in remote area and they are weak and they are not able to inform the hospital and not departments. So this thing we can also do. So एक चीज को check सकते हैं silent to mute हो जाते हैं last में विचार होता है तो उसके क्या हम क्या मैसेज बाइसेल कर सकता है और उसके लिए असिस्टेंस और भी डेवलप करते हैं and also
So,
sorry, in continuation of what Principal Sir said, आप किसी भी पेशेंट को जब कोई फिजियोथेरेपी कर रहा है पेशेंट का एक फोन ले लीजिए, उनका रिलेटिव वो वीडियो बना उनके ही फोन में, फिर वो घर पे देखेंगे तो उनको इजीली रिकलेक्ट हो जाएगा कि कैसे मैंने एक्सरसाइज कराया. दूसरा, अगर इस तरह के केसेस में जो सवाल मैंने पूछा कि एक महीने मान लीजिए वो घर में फिजियोथेरेपी नहीं करती है तो कैन शी गो बैक. आप पेशेंट को ये इंस्ट्रक्ट करें कि हर 2 हफ्ते में और 4 हफ्ते में दैट पीरियड यू डिसाइड आप अपना एक वीडियो बना के कि आपकी एक्टिविटी कितनी है मुझे भेजिए. अगर आपको लगता है कि पेशेंट इज गोइंग डाउन तो आप उसको मोटिवेट कर सकते हैं कि फिर से आओ हमारे केयर में या कहीं बार फिजियोथेरेपी कराओ. सो यूज ये जो व्हाट्सएप है इसको थैंक यू कांग्रेचुलेशन और फॉरवर्ड करने की बजाय पेशेंट केयर में अगर इस्तेमाल करोगे तो उसका बहुत फायदा होगा.
also require.
Yes.
So, many patients, they are not reaching this physiotherapy clinic because large chunk of physiotherapy patients, about 70% would need a physiotherapy. Whether it is head surgery, whether it is breast surgery, and for these kind of surgeries. So I think if we start sort of a screening program, students from here can come to the public department and the patient daily, 150 patients are being treated daily. So if they can screen which patients need physiotherapy, they can be easily we can make them a regular visit while they are
Let
taking.
me ask, practically speaking, when you said that as a part of holistic care, you refer patients to physiotherapy department, you mean physiotherapy department of the hospital?
Yes.
We use of all these students.
So they are from finger, they can sit down.
We can visit
Yes, sir. Under this school, we have around 80 members. People and working towns and like primary.
us suggest कर रहे हैं कि अगर young people जो is they are posted by rotation, इसलिए concern
Sir, actually, the students are admitted to the oncology surgical posting. There is Dr. Rajveer, sir,
radiotherapy में भी posted.
students are admitted. कि हमारे पास 30 दिन के पेशेंट है, 3 दिन रुकेगा पूछेगा उससे. So we create a appointment at the next from the next hospital for your department. जैसे 70 के पेशेंट्स को पक्का चाहिए. उसके अगर cancer-related fatigues are always there and they require this one.
That's a very important point because surgical oncology का जो patient दिखाने आ रहा है, वो दिखा के घर चला जाएगा.
जी सर.
इनके बाद जो patient आते हैं, complete day of the week, 4 से 6 हफ्ते तक रोज आएगा. It's a very good opportunity for the students to get attached to one patient.
Yeah, sure.
आप उसका मैकेनिक्स डॉक्टर शायद के साथ
Our daily exams are posted there in surgical oncology. One will be we can keep marks under sir.
it will help the patient and it will help the students to see more patients to do more. Please go ahead.
So as per the guidance of our experts, it is very important to make sure that follow-ups are to be done regularly. And patient's treatment is not for the 30 days that the patient is here with us. Maybe when the patient goes home, and it is our job as well to take care that the rehabilitation does not reverse, and the patient maintains that physical activity as well as improves our activity. So next, it is always said you are not progressing forward if you are not using or going towards the advancement. So let's talk about the advancement in the physiological and physiological aspects of the patients that we deal, like the hemiparesis case, for which I would like to invite Dr. Ashis Sharma, PG resident, and he will be demonstrating as well as explaining us some new advancement in the field of physiotherapy.
Good afternoon, all of you. I am represent my topic advanced neuro rehabilitation for hemiparesis. These are some devices which we will discuss further. First one is robotic gloves. Second is arm and exoskeleton. Third one is virtual reality system, robotic gait trainer, recumbent pipe, and AI brain shield. First one is robotic gloves. It is hand-based device which are useful in hand rehabilitation for hand fine movements. It delivers high repetition for effective functional recovery. It also be programmed and having mirror motion of the unaffected limb. Here, this patient is unable to move his left hand properly. Here, this patient doing fine movements. दोनों हाथ को सीधा मत धीरे धीरे इसको पूरा खोल दो हाँ खुलवा दो पूरा I'm showing this demo. इसमें दो मैनुअली भी इसको चला सकते हैं और मैकेनिकली। इसमें मैनुअली में मैं मुझे मोशन करूँगा लाइक अनअफेक्टेड लिम्ब से पेशेंट है अफेक्टेड फीमर ये मूव नहीं कर सकता लेकिन ये मूवमेंट हो। Flex my fingers. Now open my hand. पेशेंट के साइकोलॉजिकल काफी ठीक होता है। इस पेशेंट घर पे इससे एक्टिविटी कर सकता है, ब्रीथिंग सिस्टम हो जाएगी। फिर इसको इसके एडवांटेज है इससे पेशेंट्स की इजीली मूवमेंट कर सकते हैं। ये इजी टू यूज है, घर पे भी इसको यूज कर सकते हैं, पेशेंट को सिखा के दे सकते हैं। अगर वो हमेशा अपनी क्लिनिक पे या सेंटर पे नहीं आते हैं तो ये पोर्टेबल है और अफोर्डेबल है। अब इसमें थोड़ा डिसएडवांटेज है कि लिमिटेड इसकी एविडेंस इतनी नहीं है, रिसर्च इतनी नहीं है जो इसकी एफिकेसी के बारे में बता देती है। और कंडीशन लाइक रिलेटिव इसका ये यूजफुल नहीं है। पेशेंट रिलेटिव है तो इसका पूरा मूवमेंट नहीं होता है, हैंड ओपनिंग पूरी लिमिटेड होती है। Second is arming exoskeletal drugs. It has 6 actual degree of freedom. Like shoulder में 6 degree freedom यानी 6 अलग-अलग डायरेक्शन से मूवमेंट कर सकता है। शोल्डर्स के लिए फ्लेक्शन, एक्सटेंशन, अडक्शन, एक्सटर्नल रोटेशन सारे मूवमेंट्स एक साथ कर सकता है। लाइक पेशेंट्स को कोई टास्क है मूविंग करनी है तो उसमें सभी का कंबाइंड मूवमेंट होना जरूरी है, तो उसकी हेल्प से हम ये कर सकते हैं। इसके एडवांटेज ये वेरिएबल डिवाइस है, बॉडी पोजिशन मूवमेंट लाइक ओवरहेड एक्टिविटी, कॉम्बिंग करना कोई टास्क ओरिएंटेड चीज इसलिए हेल्प से कर सकते हैं। इंटेंसिव मोर रिपीटेशन एक्सरसाइज हो जाएगी एंड इससे एडवांटेजेस हाई कॉस्ट भी है और इसकी अवेलेबिलिटी भी कम है।
One of the key challenges in automation is the collaboration between automated systems and the human co-workers. Today, most robots still operate in strictly separated workspaces from humans. However, today we'll introduce some powerful robotic systems. One of the key
Next is working reality system. In this patient here, they mounted with motion tracking sensors plus dental media simulated virtual environment. They can perform exercise and activity in a safe, controlled environment and receive real-time feedback. The beneficial this immersive technology facilitates patient rehabilitation by improving motor skills and balance. Like patient sitting में इसकी हेल्प से गेमिंग करा सकते हैं तो उसके सिटिंग बैलेंस ऊपर होगा। It has also psychological value. Next is robotic weight roller, also known as locomet. It is useful for lower extremity rehabilitation. It is most popular body weight supported element and exoskeleton. इधर पेशेंट को एक बार एलिमेंट कर देंगे तो इसमें ज़्यादा गाइडेंस की जरूरत नहीं होती, वो गाइडेंस से उसको ट्रेन कर सकते हैं। रोबोटिक वेट रोलर इसमें पेशेंट्स के लोअर डिटेल रोबोटिक पैटर्न्स होता है। इसकी हेल्प से मोर रिफ्रेशर्स कर सकते हैं पर सेशन, देन मैनुअल थेरेपी, थेरेपिस्ट में बर्डन रिड्यूस हो जाएगा डिसएडवांटेज लाइक कॉस्टली है, अगर पेशेंट के पास सिटी है वो रोबोटिक यूज कर रहे हैं तो अगर ज़्यादा कॉस्टली मूवमेंट होता है तो फ्रैक्चर के भी चांसेस हैं। और ऑल्सो गलती सजेस्ट recommend by motor system. Like recommend by car is expensive for stroke survivors. They want to build up the skills necessary for walking. Bikes encourage bilateral movement, which is helpful for individuals with hemiparesis because the non-affected leg can assist the affected leg. Its benefits are it helps to perform high repetition exercise combined with increased heart rate, portable, lightweight, and easy to store. It improves upper and lower limb motor ability and strength, balance, and cardiovascular fitness. Future of neurorehabilitation is artificial intelligence brain chip. It is nothing but a coin-sized device that is implanted in the skull to monitor and potentially stimulate brain activity. Current technology uses a single chip implanted over a small area of the brain, gathering information from only a few of the billions of neurons in our brain. अभी फ्यूचर कोर्सेज के मल्टीपल चिप्स को इम्प्लांट करें और पूरे ब्रेन की एक्टिविटी और उसके इन्फॉर्मेशन लेके लाइक मूवमेंट करवाना, ब्रेन से कंट्रोल जो मूवमेंट होते हैं वो सब इसके यूज से करवा सकते हैं। अगर ये सक्सेस होता है, मूवमेंट टाइप चल रहा है तो पेशेंट्स के लिए काफी वरदान साबित होगा। थैंक यू।
Thank you so much, Ashis, for explaining us very clearly the recent advancement in the field of neurology and rehabilitation. If the session is open for questions, any of the students has any question regarding any of the doubts, they can ask. And after which I would like to call our principal sir, Dr. Mahatma Tiwari sir, so he can come forward and provide us with some suggestions and guidance for the students.
Good afternoon. I would go back to the professor. Dr. Sangari Chidiki sir, Professor in the Department of Surgical Oncology, and Madam Shika Khan, Associate Professor from Radiation Oncology. We do warm welcome to all of you, sir and madam. You are given your very precious time for to come here and to guide us more about how to help do good work for the cancer patients and see our 20 members are regularly going in your department and our PTS students, our internship and our final students are working there. We need your guidance, your support, how we can use our manpower for the better outcome of patients. Because basically patients, they come in your department regularly and we need your excellence to treat this kind of patients. And we are, if any kind of like extra manpower services, what you are expecting and support, what we can do more and more or better of the patients. We can also provide the work in terms of the guidance and what you are telling, how the patients are coming, and then we can work on good patients so that they can get better rehabilitation and they can resume their previous lifestyle. What patient is getting steps, कोई पेशेंट आता है तो कोई नहीं सोचता है कि कौन उसका अपने ट्यूमर निकाल दिया या फिर उसकी जो नॉर्मल जो ट्रीट करना होती है पेशेंट रिवर्स लाइफस्टाइल जैसे अपने आप को एडजस्ट करे तो प्लीज पॉसिबली एक्चुअली सप्लीमेंट्स रिप्लेसन कराएंगे वी आर ऑलवेज रेडी सर and now the session is open for discussion. If anyone has any question and suggestion, then you friends. Interns, any member? It was a very wonderful presentation done by all these previous speakers. Dr. Diksha, Dr. Shilpi and Dr. Ashis. they all predicted very well, very good presentation. Plus, they want to create something I got into for long-term follow-up, how we can do long-term follow-up with the patient so that we can achieve good outcome. So by means of providing home exercise program in the form of like photos of exercises, and also you can provide some video clips with patients to provide their attendant can get the video. And we can also start telephysiotherapy. So it is really it is good, like demanding of the time, because telemedicine का बहुत बड़ा concept है. इसके थ्रू हम इस प्रॉब्लम को सॉल्व कर सकते हैं. जो पेशेंट की बहुत ज़्यादा या पुअर पेशेंट है नहीं आ सकते हैं. So we can start in our department in our lab, and there will be some time, 1 or 2 hours in a week. You can start, and if any patient is really require those kind of services you can provide. And we can also start doing recommend also cycles, जैसे बताया कि पेशेंट जिसकी गेट टेनिंग में प्रॉब्लम है, वर्किंग प्रॉब्लम है, रिदम में उसकी मूवमेंट नहीं आ रही है, तो पेशेंट कैन डू एक्सरसाइज विद ऑटो साइकिल